Hikmet Ulug is here, I think.
Okay, just a moment, I will share. Sorry. Uh, Is that okay?
It's fine now.
Okay. First of all, thank you for the invitation. It is a pleasure to be here. We have seen excellent presentation with different technique and perspective. But today I will not focus on the technique, but on the way we think. Let me start here now. All of these techniques are minimally invasive, and they all address the same pathology. We often describe them using portal-based terms, uniportal, monoportal, biportal. But this can be misleading because tube-guided techniques are also uniportal. So the difference is not the portal. The difference is how we reach the pathology. Each technique has strengths and of course limitations. Tube-guided, for example, familiar system but more disruptive. Biportal system, flexible but limited within the canal. Full endoscopic, precise technique, but it has a long learning curve and requires planning. No technique is perfect. Today I will focus on full endoscopic discectomy, only discectomy. Now, as a full endoscopic surgery, we have two complementary approaches, transforaminal and intralaminar. Same philosophy and different working volumes. In full endoscopic surgery, the view is narrow and dynamic. It constantly changes. The anatomy is not exposed. You have to reconstruct it mentally. What you see depends on where you look. This increases cognitive load. You must stay oriented at all times. And this explains the long learning curve. In the transforaminal approach, we use safe working zones, the cranial and caudal parts of the foramen, which are free of neurovascular structures. These are not separate spaces, they are part of a single working volume. The key advantage is the interneural space between the exiting and traversing nerves. This can be explored often without bone resection. By changing the trajectory, we can reach different locations. This is the power of trajectory. And second approach is interlaminar approach. The interlaminar approach is the posterior extension of the same concept. Same philosophy, but different working volumes. We plan the approach based on the relationship between the interlaminar window and disc. These two approaches complement each other. Full endoscopic surgery is trajectory-based surgery. Precision is essential, and precision comes from planning. Preoperative planning defines everything. Now, let me show you what this means in practice through a few cases. Yeah, I will present the cases in four groups. Let's start with non-migrated. L45 paramedian central disc herniation. Midline decompression is required, and preoperative planning really is critical. We began with annular opening. Degenerated disc fragments are removed. However, dural compression persists. The PLL annular complex is cut, extending the decompression to the midline. And postoperative MRI sections complete midline decompression. Another case, L45 disc herniation. Extrusion is not clearly defined on MRI. Proper trajectory allows full access. Planning is very, very important. During the operation, multiple fragments within the epidural space. Sequential removal, one by one. And last control. Post-op sagittal image, and post-op axial image. Complete decompression is done. Another example, L5-S1 disc herniation, high iliac crest. Transforaminal access is limited, so we choose an interlaminar approach. The nerve root is gently retracted, a free fragment is identified and removed, and end of the operation. And postoperative axial sections, complete decompression. Last example, L4-5 central disc herniation. There is severe caudo-equino-compression. Again, the nerve root is gently retracted. A free fragment is identified. Following removal, a ruptured PLL is visualized, and the end of the operation. So, this is postoperative axial MRI sections. Now, more challenging anatomy. I would like to give some examples about foraminal extraforaminal herniations. L3 for foraminal extraforaminal herniation. Preoperative planning defines the trajectory. During the operation, in the beginning of the operation, immediate fragment exposure. And when I remove the herniation, there is annular tear. Pre and post-op MRI sections, and again, complete decompression. L3 for extraforaminal disc herniation. Interesting case. Fragments beneath the exiting nerve removed without mobilization. Now, controlled mobilization of the exiting nerve, fragment removal again and again. Continuously retraction of the exiting nerve. At the end of the operation, fine anatomy, clearly visible, even with circumneural sheath around L3 exiting nerve. Pre and postoperative MRI sections, and we can see complete decompression. Another case, another example for the exiting nerve manipulation, L3 for extraforaminal disc aeration. During the operation, the fragment is adherent to the exiting nerve. No clear plane, direct separation not possible, controlled release along the nerve disc interface, fragment mobilized and removed. Working around the axilla, reaching the target safely. It shows our trajectory. And complete decompression is done. Finally, the exiting nerve is not a limitation. It can be understood and safely managed using full endoscopic transforaminal surgery. And it is interesting case, over 80 years old woman. She has very severe pain and two-level extraforaminal herniation. With proper planning, even two levels can be treated in one session, L3-4 and L4-5 herniations. Now, a few migrated cases. L3-4 upmigrated disc herniation. In the beginning of the operation, L3 exiting nerve exposed and fragments located caudally to the exiting nerve. We are removing the fragments and L3 corpus exposed. Trajectory continuously controlled via X-ray guidance and accessing the axilla and last fragment removed. Postoperative axial sections, and postoperative sagittal and coronal sections, we can see complete removal. Another example, L4-5 upmigrated disc herniation, MRI contraindicated for this patient. Controlled cranial rotation of the cannula, PLL is opened, subligamentous dissection to reach the cranially migrated fragment, fragment removal piece by piece, and finally, cauda and axilla clearly exposed. You can see that intracanal maneuverability without any bone resection, maneuverability inside the canal. Pre and postoperative CT sections, complete decompression is done. Another example, L2-3 down-migrated disc herniation. Interlaminar window was not appropriate, and we choose transforaminal way. We start exposing the L3 pedicle and circumferential foraminal enlargement, stepwise drilling of the vertebral body and pedicle. Migrated fragment and migrated fragments are removed sequentially. Normal anatomical relationship are restored. Preoperative MRI sections and postoperative MRI section. I would like to show that this is the circumferential foraminal enlargement. If it necessary, we can enlarge the foramen by drilling dorsal surface of the corpus, cranial surface of the pedicle, and superior articular process. Another example for down-migrated herniation, down-migrated fragment at L3-4. The relationship between the disc and the interlaminar window allows direct access to the target. Preoperative planning is very important. The cauda is gently mobilized medially and the fragment is directly exposed, removed in one piece. Full exposure of the cauda, axilla, and L4 traversing nerve. Pre and postoperative MRI sections, complete decompression is done. Another example, L4-5 down-migrated herniation. I want to show the preoperative planning. The approach is planned based on the interlaminar window disc relationship. During the X-ray films during the operation, we can see that instrument maneuverability within the canal without any bone resection. And postoperative MRI sections complete decompression. So finally, in transforaminal surgery, we change the trajectory. Here, in the interlaminar system, we move within the canal without bone removal or minimal bone resection, of course. Same philosophy, different working volumes. And last group, recurrence. With recurrence, we are no longer dealing with native anatomy. There is this example is recurrent paramedian disc herniation at L4-5 after prior microdiscectomy. In the beginning of the operation, we enter directly into the epidural cavity. The disc space is already exposed. The fragment is located ventral to the cauda and removed. No need for dissection through scar. We work in different corridor. And finally, midline decompression is confirmed. Pre and postoperative MRI sections. Another example, recurrent extraforaminal disc herniation at L3-4 after prior microsurgery. Short video, a routine transforaminal trajectory. At the end of the operation, the exiting nerve is exposed with a thickened circumneural sheath. Thickened circumneural sheath reflects prior surgical manipulation, effects of prior surgical manipulation, and postoperatively complete decompression. Coronal and sagittal sections. Yeah. And last case is primary L4-5 paramedian disc herniation. I performed a transforaminal discectomy. You can see that complete removal is okay. But 4 years later, there was recurrence. This time as a central herniation and also with a narrowed neural foramen. There is a narrowed foramen, the superior articular, and the superior articular process is exposed in the beginning of the operation. Foraminectomy is performed by stepwise drilling of the SAP and pedicle. creating a new working space. The fragment is removed through the enlarged foramen. And preoperative narrowing and postoperative enlargement of the foramen means the foraminotomy. And the complete decompression following the operation. As a result, recurrence changed the anatomy, not the strategy. So, if as a summary, you have seen different cases, different locations, different patterns, but the principle is always the same. We target the pathology, we choose the trajectory, and we respect the anatomy. The approach is dictated by the pathology, and therefore the outcome is determined by planning, not by the tool. It is not about the portal, it is not about the technique, it is about the precision. Thank you very much for your attention.
We thank to Hikmet Ulug. It was really a good presentation. So we are having some questions on the right side. Leo Gabrielian is asking, when working extraforaminal, do you get postoperative neuropathy symptoms in early period due to retraction of the ganglion?
Yes, this is really good question. Uh, it is very routine for me to manipulate the exiting nerve. I began this transforaminal surgery 17 years ago. In the first years, I have one case. The case has a severe pain before the operation. After the operation, there was no problem. But 1 week later, she has burning dysesthesia and very severe pain. At that time, we don't know about this manipulation, effect of this manipulation, and we gave the patient pregabalin, and there was no problem 2 weeks later. Now, in my daily routine, if I manipulated minimally also the exiting nerve, I am giving pregabalin or gabapentin according to the patient health situation, and I have no any problem.
So Leo is thanking. Another question you may write uh, on the mailing part. So I want to ask both speakers. As a beginner, okay, which type of endoscope do you recommend us? I'm also asking to one, uniportal or biportal. Which one is easy? One is talked about it, but what do you think, Hikmet abi?
Yeah, really, I have no answer. Why? Because 17 years ago, I began with directly full endoscopic surgery, and I have no any experience with biportal surgery. But if I talk about the full endoscopic surgery, 10 years ago, even 5 years ago, there was no sufficient training programs. Now this is very common in all world. Also, the resident training program introduced the academic area. I cannot answer which one, but I recommend to begin to directly full endoscopic surgery. Also, really, I have to confess that I am the 68 years old. If I a little bit young, really, I want to do both of them.
Oh, what's Hikmet abi? Thank you for the answer. And what's the answer of one from Korea? He has talked about the advantages and also the advantages of both techniques. But which technique do you recommend as the beginners? Is one here?
Um,
So,
the one is not here, and I would like to add some another things that, in my opinion, when I search the philosophy of the full endoscopic surgery, I think that it doesn't matter because full endoscopic surgery is different. very dynamic view. I try to tell something in the beginning of my speech. And any surgeon, after the microsurgery, of course, can adapt it very easily to the biportal surgery. But it will not difference because when he go to the transforaminal surgery, he will met with same difficulties. I think that for this reason, both of them can be used in the beginning. I think that, but of course, one is not here. His experience more than me for two techniques. I don't know his idea.
So
There
another
is one
question.
question from Dr. Fadi, Onur.
Yeah, he's asking, what is the tricks to avoid dural tear in recurrence disc herniations, and how do you deal with it?
Uh,
From
during
Fatih
the
Almaher.
during the operation for recurrence
Yes.
cases.
What are you doing to avoid uh, dural tear in recurrent disc herniations?
First of all, approximately 5 years in the beginning period, I didn't make any recurrence case using full endoscopic surgery. And second one, there is no any way, in my opinion. It depends your experience and anatomical knowledge about the uh, transforaminal or interlaminar technique. Only, in my opinion, I am coming also from the microsurgery from cerebral area. We are very careful during the microsurgery in the brain or inside the spinal cord. The maximum attention is necessary, I think that. But every time we can meet with dural tear, of course.
So the answer is don't start with the recurrent disc herniations.
Yes, yes.
Yes.
But I don't know because I began 17 years ago. I don't know what about today options and today facilities to learn the surgery. I'm not sure.
So
Can
Hikmet
I
Tabi,
ask something,
Of
Onur?
of course.
Yeah. Actually, the other speaker mentioned that the Uniportal is more expensive. Do you agree this?
Dr. Zilili, yes. If you compare both of them, not so much, but of course, more expensive from the biportal or microsurgery. But it is not expensive than any instrumentation. It is not big money, I think that. I remember that 20 years ago there was no MRI and MRI was very expensive. It depends to your choice. Today is not it is not more money in my opinion. Also, just a moment, I am applying this surgery in only private area, and I have no any difficulty about the budget.
What do you think? I'm commenting on popularizing the biportal endoscopy, that it is a back step of uniportal surgeons. They feel like more comfortable with biportal endoscopy than uniportal. Because of that, it is more popular nowadays, making a biportal endoscopy. What do you think about this?
Yeah, in my opinion, my idea is there are several reasons. One of them is you can use your routine surgical tools, for example, orthopedic arthroscope and routine microsurgery, forceps, etc.
Right.
Yeah. Second one, Dr. Zileli, is the foraminal anatomy is very interesting anatomy, and in literature, really there is no real descriptions or detailed anatomy. Learning a little bit difficult. Some surgeons, I am talking with a lot of young surgeons, they are saying that, oh, it requires a lot of reading, working, etc. Because we are not familiar to transforaminal foraminal area as a neurosurgeons. But also, I am observing that the transforaminal surgery rates is increasing. That's the good. These are the real some.
Another critic is that you are you are saying that we do a full endoscopic surgery. The others are endoscopic. Do you mean this? Or
Mehmet,
partial endoscopic?
dear Mehmet, dear doctors, really, you know that this is every time is
I'm
debate
joking.
between
Yeah,
two
yeah,
and
but
you and me. Yeah. No, no, no,
yeah,
no,
yeah, right.
no. Actually, in my opinion, I am using the nomenclature from the literature every time. The
You
second,
don't accept biportal surgery as full endoscopy. Do you mean this?
yes, biportal endoscopic surgery, in my opinion, because the
It is not. It is not full endoscopy.
no. Bipolar
It's not
endoscopic
okay.
surgery, full endoscopic surgery.
I
Also,
understand.
imagine that the tube-guided surgery is uniportal.
Yeah, good.
So
Okay, thank
another
you.
question, Hikmet abi, two of our colleagues is asking, do you have any fellowship program? Do you accept fellows for teaching the skills?
Actually, I have no, but in Turkey, I am talking about the surgeons outside the Turkey. Now we have young surgeon colleagues, and they are doing these operations very intensely. So if you applied me, really, I can arrange for them some programs.
Okay, another question. In L5S1, do you use transforaminal or interlaminar in your cases?
That's very, very clear. Uh, we are living in Turkey, and in Turkey, generally, the Christia iliaca level of Christia iliaca very high. Generally, L4-5, L3-4 level. For this reason, I am not trying to transforaminal surgery. Uh, Mostly, maybe 99 percentage, I am doing interlaminar surgery. I am only use transforaminal surgery for L5S1 only if there was extraforaminal herniation. At that time, the angle is not important. I am using transforaminal surgery for extraforaminal herniations at L1, L5S1 level.
And the second question from Said Ahmed, do you have any experience for fusion surgery with Uniportal?
Actually, now I will say something, and all audience doesn't like. I am not believing the endoscopic fusion surgery. Sorry, but young surgeons are doing. We will see the results. This is the another discussion issue, in my opinion.
And another question, what about intraforaminal disc in L5S1? I didn't understand it.
Not
The
inside
last,
the canal, huh? The transforaminal, of course.
okay.
Foraminal and extraforaminal.
So, Hikmet abi, thank you so much for your presentation, for your recommendations. So, is Ortel here now?
He didn't appear since now. But we can. Salman Sharif is with us. We can ask Salman about his comments on full endoscopy, half endoscopy, uniportal, biportal.
Ortal is
Salman
Professor Silalin now. Ortal is joined.
has
We
joined.
I'm
Okay.
here.
Anyway,
Ortal here.
Salman, do you wish to say something?
Yeah, I think I totally agree with our friends that these new techniques are, very popular with young people. We all are also doing a little bit of them, not that many, but and I agree that people who are good at doing what they're doing at the moment, and if they have good results, they don't need to upgrade to this. But young people should learn all those techniques. And transforaminal and techniques are very, very good, especially now with a lot of new stuff that we can do, and there are new techniques coming up, and both the talks are superb. I learned so much from these talks, so I'm grateful to Hikmat as well as our friend from Korea, and looking forward to hearing from Joachim now.
So last question he want to ask. Thank you, Salman. Mohammed is asking to Hikmet Ulug.
Yeah.
He has problems while he's using the Uniportal system. What do you do for the soft tissue that is blocking your camera view? How do you prevent to make the clearness of the camera of your portal system?
I have no any clearing problem in my system. I don't understand this question very.
He's saying
Can I,
that.
can I
Mohammed,
ask the question, please?
yes, Mohammed, please.
Yes, I do unilateral biportal endoscopy, and I have mostly difficulty during making the portal because I encounter a lot of soft tissue in my way, and I take a lot of time to clear it from the lamina with the bipolar or with the endoscopic shaver. If there is any recommendation to help to fasten this step, like using dilators, or I don't know what to do to make the soft tissue clearance more fast?
Sorry, you are asking about
Unilateral
biportal
biportal,
endoscopy.
UBE. Yes,
Yes.
UBE. I take a lot of time. I do the portal correctly, but I find a lot of muscle tissue above the covering the lamina and the anatomical landmarks, and I take a lot of time to clear it with the radio frequency probe until clearing the bony anatomical landmarks.
So
Okay.
what do you recommend to clear the
Soft
bone
tissue
tissue?
quickly.
Yes,
Yeah.
to remove the soft tissue.
I have no any experience with UBE. And in the full endoscopy system, I have no this type problem. I cannot
Okay.
say anything.
So one is here, but I think
I
he's not
won't keep
hearing.
can reply.
Okay.
So one, can you hear us? You're here, but I think your camera or your microphone is closed. Okay,
Yes.
Mohammed, if one will join again, we will ask him again, okay?
Okay.
So,
And regarding the monoportal, I have also a question. The monoportal system.
Yeah.
Can I ask it, please?
yeah, of course, please.
The monoportal system, I also find difficulty, particularly in the step of undercutting with the cavisons, because undercutting the facet joint and lateral recess with the cavison, the walking channel doesn't allow me to tilt the cavison shaft. When I try to tilt the cavison shaft to get under the facet joint to do undercutting in the lateral recess, I find this step difficult to tilt the cavison. Do you do it with the bare system or with the cavison or with another instrument?
Actually, it depends your experience. In my practice, in the beginning period, I was using the drill system for bone resection. But in last times, particularly during the interlaminar surgery, I didn't need more bone resection. If I need it, I am using the Kerrison punch. The 15 years ago, Kerrison punch was a tube shaft system. It is very difficult to use it, and now there are new system Kerrison punch, and I am using Kerrison punch. I have no any difficulty, but of course, if you make the extensive bone resection, is different. It is different. At that time, you can use the stenosis endoscopes. This type endoscope is different than the normal endoscope. They have a wider working channel. You can use it. It depends to your experience.
Okay. Okay, thank you.